And thank you for those of you that have just joined. We're very tight. We've got quite a few speakers to get through during this lunchtime period. So if you don't mind, I think we will probably kick off. And apologies, we'll be having people join, I think, over the next few minutes, but we've got a lot of you already on. So just on behalf of the team, I'd like to say welcome. And again, thank you very much for giving up the time to come to this webinar. For those of you that don't know me, I'm Mon Fletcher. I'm currently at both Edinburgh University and Oxford University as an honorary senior research fellow. Have been working with Tiny Medical for many years, really, in various guises, and it's great to see this work brought together today. So hopefully you'll get a better understanding of what the digital passport is all about, and also the evaluation that has happened. And also we're joined by other people on here today who will also bring a bit more diversity to the lunchtime session. So just to let you know, we are recording this, so I hope you don't mind, but just to make you aware, we're going to try to handle questions in the chat. Unless we do get an opportunity, we can unmute you later, but if you can ask questions in the chat, it might be better for us to keep this to an hour's webinar. So thank you. So I'm going to go straight into inviting our first speaker to talk actually about the whole of the project, really. So over to you, Greg. Greg and I have known each other for a little while. Greg is a clinician, as I am by background, and is also the clinical director of the Digital Health Passport. So Greg, over to you. Thank you.
Thank you so much, Mon, and thanks everyone for joining today. I see quite a few familiar names on the list today, so I'm just going to get in early in case I forget at the end, but to thank everybody who's participated in this project across all the NHS providers and with the partners we've worked with as well. Thank you for your support, and thank you for your ongoing support on this as well. For those that don't know me, my name's Dr. Greg Birch. I work as an A&E doctor in Brighton, clinical director and co-founder at Tiny Medical Apps. I'm going to talk today about our MyPass project, which is making young people's asthma self-management smarter with the Digital Health Passport. We go to the next slide, please. So this project has been funded by NHS England via SBRI Healthcare. This is a funding body to fund small companies and innovations that are working in partnership with the NHS at different levels of their readiness for identified problems. So this was this call was out for child health, particularly in respiratory, and we answered this one in 2023 with this project. Next slide, please. So what problem were we addressing? As you all know, I'm sure in this room, asthma is the most common long-term condition among children and young people. But we also know that emergency admissions for asthma are strongly associated with poverty and deprivation. Independent of the prevalence of asthma, if you grow up in poverty, you're much more likely to have your asthma under poorer control and much more likely to have exacerbations. And we also sadly know that the UK has the highest, or amongst the highest, mortality rates in Europe for children and young people compared to comparable countries in Europe as well. So we know what problem we need to address. Next slide, please. So our focus is on 13 to 25-year-olds, young people under 25, but also the carers and parents of people under 12 years old. We need to target our efforts specifically on areas of higher deprivation, and we need to bring evidence-based interventions together into one place. So that's really what we've been trying to do with this project. Next slide, thank you. So if you ask young people, as they did across London with the Healthy London Partnership, as they did with the Strategic Clinical Network in Manchester, and as they did in Shropshire, young people will say that they want digital tools, they want an app, and they want everything that they can access just in one place. If you ask specialists, they'll tell you exactly which features have got an evidence base for them. And we know that the evidence for supported self-management is overwhelming. It's been demonstrated in several papers. So just a little bit about that. I'll just hold for 1 second. So in terms of where the evidence is, there's evidence for asthma action plans. There's evidence for education programs, teaching people about better inhaler technique, teaching them about what their asthma is and how to self-manage it better. Evidence around teaching people about their triggers and trigger avoidance. And there's some evidence around in medication adherence, around providing support and things such as medication reminders as well. So those are the features that we focused on. Next, please. So co-design with young people. and co-produce within the NHS, making sure you can integrate with NHS systems where at all possible. Thank you. So project started in 2017 in London, co-design and development, initial pilot in East London in 2019. We learned a bit from that. We then go back and implement the learning. We rebuild the app into version 2. We evaluate it again in Manchester, and then we refine that version. And we start planning for a larger evaluation, and we start our integration work of NHS systems. That's kind of where we got to before MyPass. So coming then on to the MyPass project itself, what we were looking to do, next slide, if that's okay, please, is evaluate the app, evaluate the digital service, to do it at some kind of scale. Ambitiously, we said we'd get it across 10 ICBs, which was maybe a bit more ambitious than we needed to be, and built in quite a lot of delays getting the governance in place. We said we'd get 5,000 users nationally, which we did, and we didn't quite get to the 350 evaluation participants, but we weren't too far off that across the streams that we tried. Just hold there for a second. When we were looking at evaluating, I mean, Kate's going to come on to this afterwards, really, but we were looking at can the app improve patient activation, skills, knowledge, confidence to self-manage, asthma control, quality of life, and also some other metrics that we added in around A&E attendances, days off school, and so forth. But importantly, next slide, please. It wasn't just about evaluating the app. We need to know how to get it to people who need it most. And unusually for an SBRI project, we were actually allowed to evaluate not just the technology, but the adoption strategies that go with that as well. So we looked at 3 streams, what we call kind of normal NHS comms, which is things that you're used to seeing, posters up on walls, flyers being handed out, pop-up banners. But we also added into this things like stickers being put onto packaging in pharmacies. Then we had working with Rotherham Respiratory, who many of you will know, where we devised a 1-hour CPD course for anyone who had contact with anybody with asthma. So any practitioner, from school nurses, teachers, anybody right through to asthma specialists. There's a 1-hour course about supporting your patients with digital tools to self-manage their asthma, with a case study was, of course, the Digital Health Passport. And then thirdly, and importantly, we thought we need to go to the place where young people are. And of course, that is online. So what we wanted to test was social media approach, mainly TikTok, but really we didn't have any idea at all if people who were watching mainly entertainment content on TikTok were going to download an asthma app and engage with it at all. So that's really what we wanted to find out. Just gonna, next slide, please. Just gonna run a little example video, the kind of things we run on TikTok. This one's aimed at parents of children with asthma, and it gives a nice little overview for about a minute of what's on the app. So we'll just start here. That's okay. Oh, no sound at my end. Just a second. Not sure if we've lost the sound. Otherwise, I'm going to have to do an impression of Dr. Badalia. There's a reason why I'm on TikTok.
Get medication reminders.
Here we go.
Does your child suffer from asthma, and do you struggle to manage their symptoms? I'm a doctor, and I'm going to show you how you can become confident in managing their triggers, get medication reminders, and view helpful resources, like what to do in an emergency, all in one place with the Digital Health Passport app. For me personally, pollen triggers off my asthma. This app clearly shows today's weather, as well as the air quality and pollen levels in my exact location, which then helps me prepare mentally for the day ahead. If your child comes across any new triggers too, like animal fur or stress, you can actually record them here to discuss them with your healthcare professional in your future appointment, or with the Asthma and Lung UK helpline that you can access via the app. I also know how difficult it can be to remember to take our medications. This app lets us set reminders so that you never forget again. It's really important we don't miss any doses. And yes, sometimes having a flare is unavoidable. If you're ever worried that your child might be having an asthma attack, hit the emergency button to help guide you through what to do, like calling 999. Download the Digital Health Passport to take control of your child's asthma.
So there we go. So that's Dr. Badalia. You'll find out a little bit more about him later. Just encourage you to put any questions into the chat. We will try and circle around to them as we go through, and probably answer them all at the end. And then if you've got any inquiries that we can't get to, we will respond to you afterwards. Anyway, thank you for now. I'm going to just hand back to Mon, and then we've got Kate coming up next. It's going to talk about the evaluation. Thank you.
Thanks, Tom. That's great. So I hope now you've got a better understanding of the project, a hugely ambitious project, as you will have heard just now from Greg. To get 5,000 users, any of you that are involved in this field was just an amazing achievement to do that. And I think you're selling yourself a little short, because I think you did really well on the number of evaluations, which really brings me on to our next speaker. And I want to introduce now Kate Chima, who's Head of Evaluation and Insight from UCL Partners, who was involved in a really comprehensive evaluation. And I think actually went more, further and far and above actually what was expected. So Kate, amazing piece of work. I've read your large report, but I think now you're going to share some of the top findings. So thank you very much.
Thanks very much, Mon. Yes, very good for sorting out wobbly tables, the report itself, but I'm thankfully just going to give a few highlights today. Could I have the next, thanks for the introduction. Could I have the next slide, please, Dom? Thank you. So very briefly, the service evaluation had three critical components, and the first of those, and probably the meatiest, was the user reported outcomes. We looked at those at T1, so time one at onboarding, and then 3 months later, after 3 months of usage, we asked users to complete these key elements at T2, at time two. So those measures covered activation, the asthma control test, age-appropriate asthma control test, quality of life indicators, and a number of metrics that we put together and called an asthma check-in. Our second most critical component in many respects is the user experience, and we looked at that from 3 different perspectives. So people with asthma themselves, their carers or parents, and healthcare professionals as well. And then finally, as Greg's already alluded to, we had a look at some of the adoption strategies that have been used, social media, those traditional methods, and the clinical kind of champions and training provision approach. Just to note at this point that users were reimbursed for completing both the user reported outcomes elements and for participation in telephone interviews for the user experience section. Can I have the next slide, please? So I'm just going to take you through a couple of key highlights. The first of those is around the patient the kind of activation measures. We used the 12 dimensions of the Partners in Health activation scale. We chose that because it was very adaptable in the asthma context, and it provided a lot of flexibility in terms of allowing versions that were suitable for both individuals and for parents and carers to complete. It has 4 levels. So level 1 against a particular dimension represents a very basic understanding, while level 4 indicates a really high level of activation and self-efficacy. And you can see the 4 levels of activation on the areas that we're interested in on the slide. Quite startling, actually, we had a statistically significant change in 9 out of the 12 dimensions. That's quite with a moderate effect size, which in this context is actually really positive. The improvement that we saw was driven by the people who were using the app for themselves, which really indicates that those who were engaging with it directly, so not necessarily via a parent or carer, were really, it was making a significant difference in terms of their activation, and that can predict a whole host of other outcomes, including, but not limited to, next slide, please, the asthma control test. So this is a clinically validated test I'm sure most of you on the call are familiar with. It provides a snapshot of asthma control over the previous 4 weeks on those 5 key dimensions that are listed on the slide. It's available in both an adult version for 12 and up and a child version for those aged 8 to 11 years, and participants in the evaluation undertook an age-appropriate asthma control test. T1 and T2 were completed by 177 participants overall, and we saw again a statistically significant mean change in the adult group, the 12+ group, which moved from an average ACT score of about 15.5. So that's kind of bordering on very uncontrolled or severely uncontrolled asthma, up to 17.04. So call it an even 17 score, which is kind of moderately uncontrolled, but a clinically significant improvement in this measure. What was particularly interesting is that when we looked at those who at baseline at time 1 were severely uncontrolled, their improvement was almost three ACT points, if you like. So they shifted entire categories, and this chart shows, so the 3 red, amber and green bars on the left there are what the profile looked like across very severely uncontrolled, moderately uncontrolled and controlled asthma according to the ACT score at time 1. And you can see you've got a complete reversal of the pattern at time 2. So a very clear impact that we can see in the ACT score. That has, can I have the next slide, please? Thank you. That drives some of the health economic modelling that we did. And it is worth noting that it is a model. We didn't follow patients through, that's a much longitudinal piece of work. But we were able to, using literature, estimate what we think the likely cost of asthma care for people would be on the basis of whether they were severely uncontrolled, moderately uncontrolled, or had asthma under control. The severely uncontrolled asthma is, as I'm sure most people are very aware, very expensive. So even small changes in the numbers of patients within this category can have a really significant impact on the overall costs. So that shift in pattern from a majority uncontrolled to a majority controlled has a significant impact in terms of the cost savings. So if we look at just 177 participants who completed the ACT scores, so the data that we had, the reduction in the likely cost of asthma care was about £43,500. If we scaled that across a typical ICB, and no ICB is average, that would equate to about £1.3 million over 3 years. So that gives us a pretty decent return on investment of about £9.28 for every £1 spent on the DHP over the course of 3 years. That takes into account population growth and also people aging out of the child and young people cohort. But it does assume static asthma incidence rates. So whilst this isn't perfect, it does give an indication of the kind of cost savings that could be driven by that really critical improvement in asthma control. Can I have the next slide, please? Thank you. User experience and acceptability is obviously of critical importance. We looked at this through a lens of people continuing to utilize the app over a long period of time. So they were obviously very satisfied. 97% of interviewed participants would recommend the digital health passport to other people. There were particular areas that were very popular. So this kind of all-in-one convenience that Greg mentioned in his introduction, reminders and air quality alerts and symptom tracking particularly. There were really strong indications of intention to continue usage, especially if people were less controlled at baseline or had perceived low control. We had some interesting insight as well into potential improvements that could be made. So, for example, improving peak flow, reading, recording, and then kind of reducing the need for preventer medication as well. So we've got some really a kind of nice holistic bunch of stuff, both from a parent and carer and the patient perspective, that not only reflects really well on the digital health passport as it stands, but also speaks to potential opportunities for future development. A couple of quotes that I've just put there that really resonated with me, and the one that I'm going to pull out is that lower one, which really spoke to me in terms of its kind of normalizing. Asthma is not something to be embarrassed about. So it's had an impact not just for the daughter who is being referred to in the quote, but also an impact on the parent who's able to deal with, who's been able to utilize it in helping her daughter kind of deal with issues at school as well. So there's a wider impact to consider, I think. I have the next slide, please. Our third element, as I mentioned, was the adoption strategies, and there's Dr. Bedelia and Dr. Emeka again. So we looked at the 3 adoption strategies that Greg's already outlined. And unfortunately, with both the kind of traditional NHS and the training strategies, it was very difficult to understand the impact that they have, whereas that can be measured quite straightforwardly with social media. And I think taking all of it into consideration, social media was as an adoption strategy, was very compelling, partly because of its very measurable reach. It had a very clear ability to target particular groups and was relatively cheap at just, I think it was £2.50 per acquisition once the kind of dealing with all of the TikTok videos and things was in-house. Having said that, more traditional approaches, particularly when we chatted with healthcare professionals, especially if they're adapted for younger children, perhaps at the point of transition to secondary school, could be more successful in reaching those who are more likely to have poor control, those who are more likely to already be in contact with healthcare services, and therefore those who could potentially benefit the most. So our kind of conclusion was that whilst the kind of TikTok adoptions or the social media adoption strategy incredibly successful and really able to target particularly deprived groups, a more diverse group of people as well, a mix of adoption strategies is probably best depending on the nature of the kind of asthma cohort that you're looking after. Next slide, please, and nearly there, I promise. Very, very quickly, we evaluation professionals, we can't help it. We've got to write a slide about limitations. So obviously, sample size is always an issue. Actually, this is a pretty good sample size as these things go. The data quality was very good. Larger sample sizes are always better. We always want more. We like to improve the power of our statistical tests. As I mentioned, the health economic components were modelled. So in order to do a kind of real world health economic study, we would need kind of longitudinal track patient DHP users through their journey so that we can estimate kind of real world likely financial impact at system level. We had a few limitations in terms of data quality, calling out particularly and not surprisingly ethnicity. It's about 12% of participants didn't record their ethnicity in the data set. And then, pardon me, finally, our kind of sample for the user interviews was a little smaller than we'd hoped. We'd looked for 75 interviews and we ended up with 38 complete. So we would like a larger sample of users because we weren't able to do some of that subgroup analysis that we were quite keen on. Next slide, please. Thank you very much. So overall, 4 key takeaways. We saw a significant change in the asthma control test and the patient activation measures. They're validated clinical and behavioural measures. They predict improved asthma outcomes in terms of reliever medication use, emergency care, and asthma exacerbations. We had those positive changes could drive economic improvement at an ICB level, and certainly from literature that is strongly indicated. Users have got really positive feedback, and using the kind of the framework that we did for the analysis of that, there's a strong indication of intention to continue use in the longer term with the outcomes that could potentially drive. And then finally, the social media focused adoption strategy really drives reach and uptake in key target groups, the 13 to 17 demographic, more deprived and diverse groups than the groups that historically have been underserved. Last but by no means least, if you too want to prop up your table, I'm sorry, next slide, please, and read the full report, which has got all of the methodological detail, all of the pros and cons and discussion. Please do scan that QR code that will take you to the UCL Partners website. And just to finish up, an enormous thanks to the TMA team, who are very supportive throughout all of this process, my colleagues at City University, who helped with some of the statistical analysis, and obviously everybody, all of the patients and carers who participated in the research. That's everything from me. I hope I stuck to time, Mon.
You did really well, Kate, and so much information. There's quite a lot coming into the chat, and I will try and pick up 1 or 2 of these questions after I think I've heard from Dom, because then that's the 3 presentations that I've focused on this project. But Kate, well done for keeping to time and lots of information. And I do recommend you, if you do want to, put that QR code up or a link later on again, because it is an easy read, Kate. So well done. I don't think it's underneath my table at the moment, so it's not being wasted. So just under that third point, which I think is really important, what was really, really ambitious of this project, or the fourth point, was actually using different medium. And I think there's a lot to be learned from this, what we've learned through using TikTok here. So I'm going to invite Dom now to come in with some of those results, who is actually the Director of Communications for Tiny Medical. And yeah, I think we're welcome to hear the results and a little bit more about the TikTok. So over to you, Tom.
Thank you very much indeed.
Tom.
Don't worry, I've been called a lot worse, Mon. It Starts on TikTok is actually the marketing campaign of TikTok itself, and it's important just to get, I suppose, some of the basics out there. So TikTok is an entertainment channel rather than a social media channel. It's the world's largest entertainment channel, and on average in the UK, people are consuming 104 minutes of TikTok every single day. And it's not just millennials and young people. It does over-index in terms of young people, as you'd expect, but half the country are on TikTok, and actually 1 in 4 over 65s are on TikTok every day. So it really is a mass market entertainment channel, and it is changing every single day. One of the ways to think of it, perhaps, is how we all think of Google. And that's why the campaign says it starts on TikTok. Increasingly, TikTok is the starting point now, where people will go and search, look for inspiration, look for entertainment, be that holidays, recipes, or health information. And that's across all generations. And that shift in behavior is increasingly going to change how people use the web and how the other search engines are going to have to react. So if you're not particularly on TikTok a lot, begin to think of it more as a search engine with lots of entertaining content. That said, the amount of time you have to grab somebody's attention is tiny, and people are having fewer and fewer seconds, if you like, for you to be able to capture them. So the maximum that you're likely to have somebody is around 26 seconds. You have to make your your content really engaging, and you really have to grab somebody in that first second as they're scrolling down their phone. So let's talk a little bit about DHP and what we did. We've already talked a little about Dr. Badalia, but we used a number of sort of infomercials, if you like, explanatory videos shot in portrait by a young professional doctor who has asthma himself and has a very engaging style. The call to action is really, really clear on those videos. And as you can see from the picture, we had around 500,000 views, so over 1.2 million over a 12-week period. We also created some meme videos using trending sounds or trending green screens. These are the kind of things that will appear one day and disappear very quickly. And we added a number of followers to the account. In terms of targeting the audience, we're very clearly trying to target a 50-50 split. Predominantly, we're aiming at younger people. And on TikTok, we're actually targeting 18 to 24s rather than younger than that. And again, that was a UK-only audience that we were addressing, although there was always a little bit of leakage on organic social. So in the first 60 days, with a pretty small budget, £1,700, so just under £2,000, and that was used to boost that content. We generated over 7,500 clicks through to the app stores. We collected some new followers, generated lots of engagement in terms of comments and likes, and as I said earlier, over 1 million views. Importantly, though, what we were trying to do was encourage people not just to be aware of their asthma or aware of the app or the functionality of the app, but actually to get them to do the hard bit, right, which is to go to the effort of installing it. And using TikTok's ad manager, we're able to do some A/B testing, targeting different creative, targeting different types of users. And as Kate said earlier, we actually got that install cost down to around £2.50. And just as sort of a measure, anything below £5 is considered to be excellent in terms of the efficiency of your ad spend. And bearing in mind that when you download the app, the registration process is quite long, and we're asking for quite a lot of information. So to actually get it down to that level was really, really encouraging. Obviously, what we need to do further is really repeat and test lots of different types of creative, because there often is with advertising, an efficiency and an attrition rate as well. Bringing it in-house. So in the first pilot a year ago, we had to use a specialist agency. This year, we've brought it in-house. That's partly to reduce the costs, but also to understand more fully the deployment of the app. We're aiming as an organisation to be much more proficient and actually offer this as a service to the NHS. So as we learn, we'll be able to be a lot more efficient with that spend, and also be able to target groups in particular geographies and particular demographics. But we do believe now that there's an opportunity to scale that media spend and actually really efficiently collect lots more young people who would be able to access the app. I'm just going to show you a couple of examples of some of the memes, because if you're not on TikTok, then these things will probably come across as a bit peculiar. This one here is actually about, regardless of what kind of asthma app you have, we're trying to encourage people to remember not to leave them behind. And this one here is another one about not forgetting your asthma app. This is a trending video, whether you believe it or not, on TikTok at the moment. It's about when your mum.
Do you know something?
Do you know something?
I might know something.
I might know
This
something
one was
too.
about.
What's the thing you know?
Oh no, I can't tell you, and she's telling me what you know.
I can't tell you what I know.
Well, then I can't tell you what I know.
Okay, fine.
And that was about actually pointing out that you can't throw your inhaler in the bin. Now, obviously, those videos are quite simple, but what sits below them is a caption that actually directs people to a lot more information and uses certain hashtags so that they're more likely to bump into that content. If you want to have a look at our TikTok channel, please do. But I will now pass back to Mon. If I can unmute you, Mon. Hang on a moment. There we go.
Lovely, thank you. And I'm really sorry, everyone, that is a bit rushed, but Dom, you will certainly be putting the linking about the TikTok channel, won't you, for everybody? I mean, we're doing okay for time. I'm sorry we're punching along pretty quickly here, but we are about to go through one of the most major changes in the management of asthma with the new guidelines that will be coming out fairly soon. And I'm sure there's going to be an absolutely really important place for you guys to be in there with this TikTok channel to try and help change the way that we really shift the way we manage asthma going forward. So we probably all need to have a conversation about that and how you guys can be center stage using some of the materials, but actually new materials that we're going to have to produce. So thank you. I've got loads of questions, but I'm afraid we're going to have to keep moving on. So I'm going to now move on to Laura. So it's great to see you, Laura. Lovely to see you and all the fantastic work that you do. For those of you that don't know Laura King, she's a senior children and young people's asthma practitioner for North East London. And Laura is going to share something that she's been working on, the new animated multilingual asthma resources for children. So over to you, Laura, and thank you.
Hello, thanks for that, Mon. So my name's Laura. I am, as Mon has already said, senior asthma practitioner for North East London, and that means I work on the asthma practitioner pilot that I'm sure we've all heard a lot about over the last couple of years. And when I'm not seconded, I'm a clinical nurse specialist for children's asthma over at Barts. So as Mon has said, this is a hopefully very, very on time, quick presentation about some really exciting resources that we've been making. Next slide, please. So I work in North East London, and I recognise lots of faces and names on the chat, but that is a very, very deprived, very diverse area that can be quite. It's really, really interesting place to work, but it can be a really tricky place to kind of get health information out there and do large scale change. As you can see, we have a lot of boroughs, we have a lot of hospitals, we have a lot of trusts, we have 15 RPCNs because we have a new one as of a couple of weeks ago. And health information can be really difficult. Next slide, please. So this project came about through the Safe Discharge Project, which I'm sure a lot of you have already heard about. We had a booklet that we embedded in our whole network, but feedback from both our teams and our parents and carers were very strongly that people were really concerned that our families wouldn't understand the information. We thought, and patient information thought, that it was easy to understand, but it certainly wasn't easy for our families who perhaps have low health literacy and certainly low English literacy. So I think you might need to click, sorry, Dom, there you go. So this is, if you're not familiar, this is a breakdown of our acute attendances from the national dashboard. Hopefully you can see it's very small text. We've got a pretty shameful inequality split where I work. So if you look at the graph, quintile 1 is an index of deprivation, quintile 1 being the worst, and quintile 5 being the most affluent families. And if you can see the descriptors, the bars are sort of generic ethnic categories. So in Northeast London, if you are Asian and you are in the lowest sort of quintiles of deprivation, you are incredibly more likely to attend ED. Essentially, we looked at our patient information and just realised that it wasn't good enough to only be in English and not good enough to be sort of not in an easy to read format. Next slide, please. I'm going to whiz through the next couple, is just to give a little bit of context about the information. So if you have a look at the two halves of these slides, these are sort of risk factors, if you like. So one, why do children have attacks in the first place? And on the right, risk factors for a severe or life-threatening attack. You can see the themes here are often understanding, inability to recognise symptoms, and of course, social deprivation. Next slide, please. Again, I'm sorry if people have already seen this slide, I use it quite a lot. These are 5 very real children that died in my patch in terms of the themes of their deaths. And again, we can see that the theme, poor understanding, poor response, poor sort of appreciation of asthma as a long-term condition and what to do in an emergency. And this is where the idea of animations came from. We really wanted to make things easy to access and things that we could share with our families. Next slide, please. So essentially, if families don't understand what asthma is or why inhalers work, they're very unlikely to manage well, as we know, and they're very unlikely to use their medication. It often comes down to something that in asthma we call the 5 brilliant basics. Next slide, please. Sorry, Dom. Or the 5 pillars of asthma care, which come down to essentially understanding what asthma is, how and why the meds work, good inhaler technique, having a plan, and knowing when to seek help. And as you've seen, these are really pertinent themes in good asthma care, but also sadly when it goes wrong and children die. Next slide, please. So I was really, really lucky to secure some Bart's charity money with the idea that we would make these sort of accessible resources. So this included having our information booklet translated into 15 languages, and we're also getting an asthma plan translated. We're just working on that at the moment. But what we're here to talk about is the educational animations. So essentially, we made a 1-minute animation for each brilliant basic. So what is asthma? How inhalers work? How and why we use spacers, and that includes a tidal breathing description, so children can kind of do it along with the animation, using a plan and staying safe. We're going to show you obviously the English ones today, but we are almost there with getting our 12 languages. So hopefully they'll be on the YouTube channel shortly. If we do share the slides, that link is clickable. So as we have languages, we'll be sharing them. But it's just English that's live at the moment. Next slide, please. Gosh. So feedback so far from parents is really positive, really overwhelmingly positive. So 80% learned something new, which is all we can ask, really. We also asked some questions around the timings and sort of how understandable they are. Really pertinently, we've had quite a few families that actually were really confident. They watched the video and realised how little they knew. So some of the data's been quite tricky. And I've highlighted the one yellow that really kind of stood out. Actually, I'm embarrassed to say I had no idea what asthma was, and this is a parent who actually considered herself quite confident. So really quite frightening. Next slide, please. So I presented these animations to North Thames a couple of weeks ago. So again, apologies if anyone was in that too. And after that session, I had over 80 emails asking me for the animations, which was really exciting. We've also had really overwhelmingly positive reactions to both the idea, the animations themselves, and how people are going to use them. So ideas that we didn't think of, which is brilliant. Things like putting the QR code in clinic letters, and sort of playing them to sort of preempt reviews rather than sort of safety net afterwards. So that's really, really lovely. And it's just really lovely to see the work be shared. You know, it's not just for us in Northeast London, it's for everybody. Next slide, please. So here's some feedback that just kind of meant a lot, sort of knowing where the ideas come from. So I think the one I like the best is, and this was a really strong theme with the sort of qualitative survey we've done so far. You know, this will help keep my most vulnerable children safe, the ones that we really worry about. Which is really lovely. Also, just being sort of a pedant, it's quite nice to see people noticing that the anatomy is accurate and some of the inhaler colours are accurate. So that's just lovely. Dom, the next slide is video. I don't know if we'll have a chance to play all of them, but I don't know if we just want to see how far we get. And I can share the link in the chat. While I wait for the volume, it's actually voiced by one of our asthma nurses, which is really lovely.
Asthma is common. 3 children in every class have it. Asthma affects your breathing tubes. Imagine your lungs like an upside-down tree. Asthma is a problem in the smaller airways, a bit like the smaller branches on our tree. The inside of the breathing tubes are inflamed. That means red, sore, and swollen. This makes the tubes twitchy, sensitive, and more likely to have an attack. This can get worse with triggers or when we are unwell. There are things we can do to help asthma. Take preventer medicines, usually inhalers. Understand what causes your problems and avoid triggers. Having an asthma plan helps you to know what to do. If you have asthma, you should have a preventer inhaler. This is the most important one for keeping you healthy. The preventer or controller is usually a tiny dose of steroid that works exactly where it's needed, in the inside of the tubes, to help calm down any redness and soreness. It is important to use it every day, even when you are well, and it takes a few weeks to start working. Your reliever or rescue inhaler does a different job. There are muscles around the tube that look a bit like elastic bands. When we are tight or wheezy, these muscles are squeezing the tube, making it hard for air to get through. The rescue inhaler tells the muscles to relax and open the tubes up, meaning it is easier to breathe. Only use the blue inhaler when you really need to.
I don't know about anyone else.
Shall we have a little stop? I think the video...
Yeah, I've just seen the chat. I put the link in so that people can watch them, because I appreciate that it's 5 whole minutes. Yeah, thank you very much.
No, I wasn't trying to stop you there at all. It's just that it's not rolling on, so we can get the voice, but not the video. I'm sure it wasn't just the lungs all the way through, Laura. So, yeah, that's a real shame. But amazing work you're doing there, and I think, you know, with the conversation we just had with Dom previously about, you know, using other channels, and perhaps, you know, maybe TikTok comes in here somewhere as well, and how you guys might work together on that in the future to get this out, because generously, as you've said, this is not just for people in your patch. You want to get it out as much as possible. So yeah, don't look so disappointed. I can see it on your face. It's because it hasn't run through. So, but
no, it's fine. It's lovely to be here. Thank you.
Thanks so much, Laura, and thank you for all the brilliant work that you're doing. We will roll, as I say, get a quick chance to speak together. So I'm going to just hand over to our last speaker, Naomi Watt, who also is doing some amazing work with Asthma and Lung UK. We can't do any of this work. You know, we can do as much as we can to educate patients, but actually what we also need is actually a well-educated workforce. And Naomi's going to share some of the work and new resources that Asthma and Lung UK have been doing for healthcare professionals. So thanks, Naomi, over to you.
Thank you, Mon. Hello, my name's Naomi. I am the Healthcare Professional Engagement Manager and a respiratory nurse at Asthma and Lung UK. Can I have the next slide, please? For any of you who haven't heard of Asthma and Lung UK, we're the national lung charity, which was formed from the merger of Asthma UK and the British Lung Foundation way back in January 2020. And we provide support through our range of health advice resources and our helpline. We fund world-class research into lung conditions, and we campaign to improve access to the highest quality care for people who live with a lung condition. Next slide, please. Looking more closely at our patient support, we are there for people throughout their condition journey, from diagnosis and annual reviews to exacerbations, hospital stay, and self-management. And we have a real focus on helping people to self-manage their conditions so that they can live well. We signpost to our helpline, our support groups, the NHS and other services. And recently we have expanded our support into healthcare professionals as well. This has happened because it is clear from our asthma and other lung condition surveys that access to good basic care for our beneficiaries has really dropped since the pandemic. COVID and the subsequent pressure on the NHS has resulted in a lot of delays for diagnosis, treatment and monitoring of asthma in particular. And with the rapidly changing primary care workforce, including the additional roles reimbursement healthcare professionals, it's become obvious that many are frequently lacking in those basic skills to manage respiratory patients, and this is having an adverse effect on patient outcomes. So to support these novice level healthcare professionals, back in June, we soft launched our Healthcare Professionals Hub. Next slide, please, Don. And this is a one-stop shop for all the resources that novice healthcare professionals need to diagnose, treat, support and review patients presenting with a range of lung conditions. It in no way replaces accredited formal training, but it supports safe and evidence-based practice. So here it is on the right, you can see how it looks. And so far up and running, we have asthma in adults, COPD, resources for your patients, which is our range of health advice literature, training and development to signpost healthcare professionals to where they need to be. They can also sign up for newsletters, and they can use our helpline. This is a resource that isn't just for patients, it's also for healthcare professionals to ring in and get the support they need. In terms of uptake, the hub has been received really well so far. We have around 800 sign-ups to our newsletter, and we're sitting at about 50,000 views at the moment. So as we continue to push out more and more content, we hope that that will increase. And here in front of you, you can just see the QR code to take you directly to the Healthcare Professionals Hub. So, Mom, would you like me to take one hat off and put on another?
Oh, sorry.
What hat are you putting on now then, Naomi?
Well, so I think Greg just wanted me to talk a bit about the changes and what's new for the digital health passport in 2025. So taking off my AL UK hat and putting on my digital health passport hat instead. So we recently had a really comprehensive look through the user experience of the digital health passport, and to do that I used a fairly standard user experience model that you can see here on the right. And what came out of that were a few interesting points, really. One was that we need to simplify the journey from homepage to video. There are slightly too many clicks to get patients where they need to go. So that is on the radar for future development. And then we noted that at the end of each video, there needs to be next steps for the user, because they need to be enticed into finding that next bit of information that perhaps they didn't know that they needed, or that they didn't know was available to them. And then another issue that came up was that the YouTube videos weren't playing particularly efficiently or particularly quickly within the app. And it turned out that that was actually a YouTube issue. It wasn't an app issue. And that led us to think that what we'll be doing in future is to develop a early warning communication to the users to say, actually, there's a bit of an issue here. Bear with, it's going to be sorted out, rather than have people come and report an issue with the app, to be proactive about flagging up when there are issues going forwards. So that's what came out of that piece of work. If we could have the next slide, please, Don. So in terms of content for the next year or so, we are really keen to get MART and AIR information up there, and some tutorials on how to use both of those, supported with the relevant health advice information. And then we're keen to expand into the university experience regarding that point at which young people go into a more adult world and need to be aware of issues with going to university, whether that is being in charge of ordering your own medication, whether it is knowing how to use a prepayment certificate to keep the cost of your medications down, some advice around university life in terms of accommodation, damp and mold, which we know are really prevalent in university accommodations. And then expanding some advice into the world of drugs and vaping, as we know that those are particularly pertinent issues for young people at the moment. So very happy to share the any of the results that came out of that review, if anyone has any interest. But that's everything from me. Greg, I don't know if there's anything that you'd like to add.
Oh, Greg, sorry. Coming. There you go.
Well, just thank you, everybody. I have to say, Laura's videos, I think some people got to see them. Laura, you'll be pleased to know. It's still for me, but I have seen them. They're absolutely fantastic. And I can't wait, hopefully, that we'll be putting those on the app next year as well. Thank you, Naomi, as well. Yes, and we're going to be working on getting everything optimized. I think at all areas of what we've done with Digital Health Passport, there's room for improvement. There's room for improvement in getting it out there, getting it into people's hands, getting people through the onboarding. Dom talked about, the getting people to install the app, but we still lose about half the people that install the app pretty quickly when we get them to register. So there's room for improvement at every angle. And there's room to optimize the education programs and take on what Naomi said to make sure we get the most of it. There's room for improvement with the content. We need to look at the new guidelines. We need to look at MART emergency plans. So there's a lot still to be done. But amongst all of that, just a little bit of a direction of where we're going. We're working on epilepsy at the moment as well. We're working on an interface for young people with learning disabilities and autism to kind of have some voice controlled features. A really stripped down version of the app that someone with mild to moderate learning disabilities could use it. We've been doing some work on sickle cell, and we'd like to move into doing some work on mental well-being and around childhood obesity, really about prevention of type 2 diabetes, that piece is. We're integrated with NHS login, which means in the areas where we're commissioned, it'll effectively be like a local app. You'll be able to kind of take ownership of part of the app and put your own contents, resources and links in there as well. Just going to quickly scoot through, Dom, we're just going to rush through these slides for a couple of minutes. So just sort of a bit of a recap. What we're doing is trying to reach and engage people with the campaigns that we do, coaching and support them through the app, but also some monitoring and oversight of that as well. So we just really run through these. We've seen a little bit about the campaigns we do in the social media strategies. Go through. This is the demographics, and I've been getting asked about this. So of the first 5,000 users, it was just over 50% were from the top 2 most deprived quintiles, and that's gone up a little bit in the next 500. And in the evaluation, it was actually 54% were in those top 2 deprived quintiles. 76 people identify as white from some background or non-specifically there though, and 65% female it was there, and 67% under 25. So we're aiming for the under 25s, but there's no upper limit on who can use the app. Just keep going quickly. I'll just dash through these. That's a bit about the app. You can find that anywhere. Keep going, see where we end up. So actually seeing what people are tracking on the app as well. So we know from the first 5,500 users, we've got about 1,200 of them are tracking symptoms on it. There's nearly 10,000 sort of yellow level symptoms which correspond to the yellow part of the action plans. So this is people whose asthma's not in control, and red is really emergency level symptoms. Keep going a little bit. Also, as many of you know, you'll be able to actually see who's downloading the app in which regions, right down to GP level, and you can see which parts of the app are being used, which videos are being watched, and so forth. Anonymous, it's not on an individual level, it's not a clinical system, but it gives you an overview of what's going on. And lastly, we're doing a project with the Greener NHS team as well, which is looking at encouraging young people to choose lower carbon inhalers, which we're working on with the Greener NHS team as well. So that's where we're up to now. Thank you all so much for coming. I'm just going to hand back to Mon and see if there's any questions or anything pressing that we can cover in the last few minutes. Thank you.
Yes, Greg, there was one, and it alluded to when you just said that this is not a clinical system. Somebody asked very early on, and I'm sorry, I can't remember who it was, but I clocked it. was how do you feed back this information, or do you feed back, or is there a way that you encourage the young people, parents, to feed back to the healthcare professional? I know this is about self-management, and really, actually, this is what we're wanting to do, get people to be able to self-manage. But also as healthcare professionals, there is a concern that they're not perhaps picking up some of this really valuable information. So what do you encourage the young people themselves or families or the users to do with that interface with healthcare professionals?
Yeah, thanks, Mon. So we're going really through some steps. The first step is the app is as a standalone. It's replacing sort of paper diaries. So people keep the symptoms on the app. They bring them into a clinic appointment, or see their GP, and they show the symptoms in a way that works for them. It's easy for them to track them. The next stage is we'll be able to then have that kind of downloaded as a PDF and potentially emailed to the clinician that they can upload to the record. So that's the sort of the first sort of the next way to do that. Building it where you've got dashboards of data and people monitoring symptoms. This is a massive piece of work, because you need someone triaging that data. There's an expectation from patients that someone's actually looking at that data then. So that's kind of beyond us really for now, until those kind of systems are in place. But there's all sorts of things will happen in the next couple of years with people being able to, you know, automatically flag red flags and potentially predict, you know, people who are at higher risk from the tracking. But we'd like to do more integration where we've got NHS login. The first step is patient focused, which is giving them access to parts of the GP record that help them. So being able to order repeat medications, but then also set up reminders, watch the instruction videos, track the symptoms, track if they're using their medications. So that's the sort of first bit of integration that we'll be working on.
Fantastic. And actually, I'd just very quickly like to get Laura's view on that as a you know, practicing healthcare professionals, how you feel about that, and happy your patients are using the passport or standalone, or it'd be great to get your view.
A bit of a mix, to be honest. So I think I've said this before to the team. You know, we find patients, sometimes we use particular aspects as a hook, and for some patients they will use it a bit more, I don't know what the word is, more thoroughly, I don't know, and we'll use sort of more aspects of the app. But a real mix, really depending on sort of, yeah, the age, and certainly the parents' sort of experience as well, I think is quite strong.
Yeah. Anything you'd like to add, Naomi, before we on this point?
It's certainly we notice that there is a constant demand for the app, and it's not always predictable who's going to use it the most, actually, but when they do, they tend to use it very, very effectively.
That's really interesting. But I think the one thing that this evaluation was not set out to do that will be very interesting is the longitudinal usage. And I think you've alluded to that during, so longitudinal studies, seeing how long people do use them. Do they dip in and out? When do they dip in? Is it when they've had an exacerbation? What, you know, whatever. We're trying to stop people from having exacerbations, but that longitudinal use and nudges and so forth is interesting. So I'm really sorry, guys, but we've got to come to the end. I just wanted to sort of run through. I mean, Greg talked about the program right from the beginning. I'd encourage, I know some of the folk on this call are innovators themselves. Remember, Greg and the team started out as innovators doing this. So what I'd encourage you to do is to really take your work to the point where you do go for these grants, because Greg has got a lot out of this grant. We've seen the quality of the work that Kate has done. Do try to get your new digital tools evaluated. And someone has nudged and asked Greg about publication. That's on the list, but I do think you really would, you know, it really would benefit from the publication. I think the bit that we saw around TikTok, there's lots to be learnt there. Thanks so much, Dom, for, you know, a bit of education as well on the purpose of TikTok. I know one of the things is it's putting out more and more material. That's how you hang people, you know, into TikTok. It's new material doing that. So a TikTok strategy is a big strategy, but it sounds to me like you are getting some, you know, return on that investment very quickly. So showing it is something that people might use. I think the multilingual aspect of your work, Laura, is just something we're crying out for. And I love the idea that you are using healthcare professionals. A little while ago, I did some work with Asthma and Lung UK about what do patients want, and they want it coming from somebody of authority. So you've taken that on board. And I think having nurses or somebody who's not authoritarian, but somebody who can authority is a really important thing. And I love the fact that you're using your team. It's brilliant. So, and everyone's congratulating you on the languages, the diversity there. And then back again to Naomi, excellent. You know, not everybody is an expert and not everybody has time, working much broader range of healthcare professionals with, you know, who need to build their knowledge up. Thank you so much for the work that you're doing, Asthma and Lung UK there. And also we've seen continuous improvement. Look, this never stands still. I mean, I've known Greg now for probably 5 or more years, and this work has been continuous, you know, PDSA cycles, what we learned, how can we move on? So well done. And thanks for the feedback that you've given, Naomi. And Greg and the team, great. You're working in a much broader range. I love the fact you're, you know, thinking about children with autism. There's quite a lot of work in there about children with with long-term conditions who have issues, you know, much broader issues. So thanks for looking at that. And all I can say finally is thank you all very much indeed. We've got lots of links in here. The team will get back to you, I promise you. I'm sorry we've been a little bit rushed, but keeping you to time more or less. Thank you all for attending, and well done to Tiny Medical and Laura and to Naomi, and of course Kate for your wonderful evaluation. So thanks everybody.
Thank you all, much appreciated. Thanks, Mon.